Welcome to our session on liver function test. Basically, it should not be called as liver function test because we do certain tests which are which can give you certain clues only when it is deranged. So we are measuring the deranged functions of the liver through liver function test. Right. What are all those tests? Before going to this topic per se, let us discuss what are all the tests that we do actually to find out whether there is any pathology in the liver or not. The first and foremost is serum bilirubin. The normal serum bilirubin is less than 1.2 milligram per deciliter. Bilirubin has got two components, direct and indirect. If direct bilirubin increased means you have obstructive jaundice, and indirect bilirubin increased means you have hemolytic jaundice. And you have two enzymes, transaminases, ALT and AST, otherwise known as SGPT and SGOT. Both of them should be less than 40 international units per liter. But your AST is present in RBCs, other tissues also, heart. So increase in SGOT or AST can be due to things other than liver. Whereas when your SGPT is increased, it is specific for liver. Right. And these two are markers of hepatocellular injury. Whereas your alkaline phosphate, GGT and 5-nucleotidase are markers of bile duct function. Whenever bile duct is obstructed, your alkaline phosphate, your gamma glutamyl transpeptidase and 5-nucleotidase are increased. Whereas alkaline phosphate can also be increased in bone disorders or in a newborn or in a growing child. It is non-specific. Whereas your gamma glutamyl transpeptidase and 5-nucleotidase are specific for bile duct injury. And then you have synthetic function. Your albumin. If albumin is less than 3 grams per deciliter, it indicates that it is a case of chronic liver disease. And finally, urine urobilinogen, usually it is negative in urine. If it is positive, it is a case of hemolytic jaundice. And if urine bilirubin is positive, urine urobilinogen is hemolytic jaundice. Whereas if urine bilirubin is positive, urine bilirubin means what? Conjugated bilirubin. If conjugated bilirubin, if urine is yellow in color, again it is a case of either cholestatic jaundice or hepatocellular jaundice. Right. This is a simple bird's eye view. Another thing that you can remember are what are all the functions of the liver. You can remember in the form of A, B, C, D, E, F. A stands for albumin. So if albumin is low, think in terms of chronic liver disorder. Ammonia is detoxicated in liver. If liver is deranged, ammonia level will increase, leading on to encephalopathy. Bilirubin. Your liver transports these bilirubin, bile salts and bile pigments. When your bile salt and bile pigments are more in urine, think about hepatocellular jaundice. If serum bilirubin, direct or indirect, based on which you can think in terms of whether it is hepatocellular or hemolytic jaundice. C stands for ceruloplasmin and coagulation profile. If your ceruloplasmin, even though it is non-specific, is less than 20 milligram per deciliter, you can think in terms of Wilson's disease. And your prothrombin time, if it is increased, indicate an acute liver injury. Your low albumin indicates chronic liver injury, whereas your increased prothrombin time indicates acute liver injury. D, I don't have anything for D, just added LDH 5. Even though you have many LDH 1, 2, 3, 4, 5, the one which is specifically released from liver is LDH 5. But basically we don't do these tests in routine practice. E stands for enzymes. Enzymes already we discussed. OT and PT, liver parenchymal enzymes, whereas Alkaline phosphate gamma glutamyl transpeptidase and 5-nucleotidase indicates bile duct function. F stands for ferritin as well as alpha fetoprotein. G stands for glucose. When liver is deranged, your gluconeogenesis cannot occur, so you will get hypoglycemia. And young infants with acute liver failure, it can be due to galactosemia, in whom if you do non-glucose reducing substances, it might indicate an underlying galactosemia. Right. So these are all the tests we often do. These are all the things that you need to remember. As we discussed already, let us club together each and everything. Your AST, ALT and LDH, if it is increased, it indicates parenchymal injury. And if albumin is decreased, chronic synthetic function of the liver is affected. Whereas if your prothrombin time is increased, it is acute liver injury, because prothrombin has got shorter half-life, albumin has got longer half-life. And your bile duct injury is represented by alkaline phosphate, GGT and 5-nucleotidase. We often don't do 5-nucleotidase because it is costly. And transport of bilirubin and bile acids. Serum bilirubin, if it is increased, transport function of liver is affected. Let's come to one by one. Serum albumin. The half-life is usually 20 days. And the normal value is 3.5 to 5 grams per deciliter. If it is less than 3 grams per deciliter, the liver has been damaged in the past 20 days. So what does it indicate? It indicates chronic liver disease. Your serum ammonia. Encephalopathy in a case of acute liver injury is mainly due to increase in serum ammonia. It can be due to a paracetamol poisoning, or it can be due to a galactosemia affecting liver at birth, or it can also be due to urea cycle disorders. Increased serum ammonia, because ammonia is detoxicated in liver. Serum globulin. Normally, we don't measure serum globulin as such. Whenever you order for LFT, you will get a serum albumin, which is 3.5 to 5 grams per deciliter, and serum globulin is 2 to 3.5 grams per deciliter. And the albumin globulin ratio is usually 1.5:1. When albumin globulin ratio is reversed, it indicates that liver has been damaged, and it indicates that either it can be a chronic liver disease. If serum globulin alone is increased, see, when there is a albumin globulin reversal, it can either be due to reduced albumin or increased in globulin. Reduced albumin occurs in liver injury, whereas increased globulin can occur due to autoimmune hepatitis. It can be due to LKM or it can be due to ANA. Aminotransferases. As we discussed already, there are two types of aminotransferases. Your OT, SGOT or AST, and your SGPT or ALT. Remember, your OT, SGOT, if it is increased, normal value is less than 40 international units per liter, both OT and PT. SGOT is present in liver, RBC, heart, etc. So when SGOT is increased, it doesn't mean that it is liver parenchymal injury. It can be due to hemolysis, it can be due to heart attack too, or it can be due to muscular dystrophies. But when your SGPT or ALT is increased, it is specifically comes from liver, so it indicates that it is your increase in SGPT indicates that it is liver parenchymal injury. Remember, when OTPT is very high, it indicates that it is a case of liver parenchymal injury. But when the high values suddenly becomes fall, it indicates that the hepatocyte cell is completely damaged. So, sudden fall in SGOT, SGPT indicates that the liver has undergone necrosis, and it indicates that it is a poor prognostic factor. As I told you already, when OTPT, SGOT and SGPT are more than 1000 and the child is sick, it can be due to the following reasons. Acute viral hepatitis, autoimmune hepatitis, ischemia, drug induced. Whereas it is, when it is less than 1000, it can be due to infections such as malaria, dengue, typhoid, lepto, or it can be due to drugs. In these two cases, the child will be sick. When the child is not sick and it is less than 1000, it can be due to it can be due to non-alcoholic fatty acid deposition, non-alcoholic fatty steatohepatitis, or it can be due to chronic Wilson, or it can be due to chronic hepatitis B or C. This is with respect to OT and PT. Next, prothrombin time. Synthetic functions, one is albumin, second is prothrombin time. Low albumin means chronic liver injury. High prothrombin time means acute liver injury, because this has got a short half-life. Albumin has got a long half-life. What is this prothrombin time? It is the ability to clot a blood sample. Is called prothrombin time. The normal value is 11 to 13.5 seconds. Clotting requires clotting factors such as 1, 2, 5, 7 and 10. Whenever there is a liver injury, these clotting factors cannot be available to form a clot, as a result of which prothrombin time will be increased. The method that they do differs from lab to lab, as a result of which international normalized ratio is followed. The normal value is 1 plus or minus 0.2. And when your prothrombin time is more than 3 seconds compared to the cutoff value, it indicates that it is acute liver injury. Remember, when you have a high prothrombin time, it can be due to qualitative defect or quantitative defect. Quantitative defects means your liver injury leading to absence of production of these factors. So even when you give vitamin K, prothrombin time cannot be corrected. So it indicates synthetic function. When prothrombin time gets corrected by vitamin K injection, it indicates that liver had produced clotting factors and the gamma carboxylation has been done by vitamin K. So when you give vitamin K and your prothrombin time normalizes, it indicates that it is obstructive jaundice and it has got relatively good prognosis because the liver is normal there. But when it is not getting corrected, when your prothrombin time is not getting corrected, it indicates that there is a synthetic defect. That's it about the prothrombin time. Serum alkaline phosphate, as we discussed, alkaline phosphate, GGT and 5-nucleotidase are markers of bile duct injury. The normal value is, let me say, 100 international units per liter, and the normal value usually reaches by 9 months. But before that, growing children have very high values. Newborns have very high values. And it is also secreted from bones too, because of rapid turnover. So what does it mean? Elevated serum alkaline phosphate alone does not indicate an underlying liver injury. It can be due to bone pathology, it can be due to newborn stage, or it can be due to growing child. So it always should be confirmed by doing a gamma glutamyl transpeptidase. Right. Remember, an unusual low alkaline phosphate can be seen in zinc deficiency and hypothyroidism. An important MCQ. Right. So look at this. Whenever you have deranged LFT, kindly see whether alkaline phosphate and GGT are increased and your OTPT are increased. When everything is increased, just compare which one is very much increased. When your OTPT is very much increased compared to your alkaline phosphate and GGT, it indicates hepatocellular pathology. Okay, hepatocellular pathology. Whereas when your alkaline phosphate and GGT are more compared to the elevation of OT and PT, it indicates pure bile duct pathology. 5-nucleotidase, costly test we often don't do, but elevation of 5-nucleotidase is specific for bile duct injury. Gamma glutamyl transpeptidase, as it was discussed, to confirm whether that alkaline phosphate elevation is due to liver injury or not. And one more point with respect to gamma glutamyl transpeptidase is, in one particular group of diseases called as PFIC, progressive familial intrahepatic cholestasis, in this condition, the child will have intense pruritus and obstructive jaundice, but your GGT levels are low in almost all types of PFIC, progressive familial intrahepatic cholestasis, except in one type, which is type 3. Right. Serum bilirubin. Normal value should be less than 1.2 milligram per deciliter. When 20% of the total bilirubin, more than 20% of the total bilirubin is contributed by direct means, it is called direct hyperbilirubinemia. So it indicates an obstruction. A confirmatory test is urine urobilinogen will be negative. Whereas if direct bilirubin is less than 20% of the total bilirubin, it indicates that it is indirect hyperbilirubinemia. It can be due to hemolysis. Here urine urobilinogen will be positive. When you have isolated hyperbilirubinemia, your OTPT, alkaline phosphate, prothrombin time, albumin are all normal. It is congenital hereditary hyperbilirubinemia. If direct is increased, it can be due to Dubin-Johnson or Rotor syndrome. If indirect is increased, it can be due to Gilbert-Krigler-Najjar hemolysis, and it can also be due to rifampicin. What is the role of ferritin and alpha-fetoprotein? If ferritin is increased, it indicates a condition called hemophagocytic lymphohistiocytosis, HLH, or it can be increased in hepatocellular carcinoma. And if your ferritin is increased, it can decrease, it can be due to macrophage activation syndrome, due to liver injury. And if your alpha fetoprotein is increased, it can be due to an inborn error of metabolism called tyrosinemia, or it can be due to hepatoblastoma or hepatocellular carcinoma. So with this, we are finishing our schedule for today. Thank you. Let's meet tomorrow for renal function.